All right, so our next speaker is Nathan Taggart from Mayo Clinic in Rochester. He was the one person who wanted to know if the table could be raised even higher than all the rest of us who aren't that tall.
Right.
He's talking about complications of pulmonary valve implant.
Thanks. No disclosures. Say again. Oh, slides. Yeah, we can do the slides. I think we have 3 questions.
Yeah, go ahead.
I don't know which 3 are coming first.
Hopefully not the last one.
It's a little battle between the first 2 there. Somebody took away their answer, looks like.
Next question.
Okay, next. Adverse events. No. Okay. I don't have this one active on my phone. Does everyone have this one or no?
Maybe we can add that to the end then
Yeah,
if we
there
want
we
to.
go.
We go to the slides. Oh, there we go. Yeah. It was working, yeah. You can go back to it. Yeah, we're jumping around. There we go.
Are you going to address these in your talk, by the way?
Yeah,
Okay, perfect.
we will.
Great.
They'll
'Cause
be
those are,
quick. So if you don't catch the answers as we go through, then let me know. We can go
Fabulous. Okay, good.
Okay. Great. So I don't have any disclosure except all these complications were not mine. Some of them were. Just keep that in mind. Just setting the stage is I'm going to go through 5 different cases, and it'll be a little bit interactive, I hope. But things to remember as we kind of go in the cath lab thinking about a transcatheter pulmonary valve implantation is it's important to individualize the risk, and particularly as we discuss it with patients and their families. I think sometimes we go in and we quote a general risk of there's a 2% chance of serious adverse event or whatever it may be. But looking at the patient's anatomy, the type of conduit or outflow tract they have, the type of valve you're anticipating using, patient size, other comorbidities is important. And this is one of the things we all enjoy doing in the cath lab, but don't let our enthusiasm sort of overpower our rational decision-making process and doing what's right for the patient, and that's been mentioned several times today. As early career people, I'm one of you, obviously. I think it's important to take advantage of your senior mentorship, either people you've trained under that may not be there with you, but people who are present in the lab or in your practice, to ask them for their opinions, to ask them for help. And that's been a great learning experience for me as I've continued on. And then to communicate with anesthesia before, during, and after the procedure. Before for an assessment of risk, during the procedure as complications may be happening or evolving, and then after, if there are complications, to go through debriefing and see what we could do better next time. Whoop, this is animated incorrectly, excuse me. So this is something I've developed. These are related to complications I've had that I've sort of created an A through currently I. Hopefully it doesn't extend too much beyond that, but things that I talk about during a pre-procedure briefing. So vascular access as I'm digging around in the femoral vein for 20 or 30 minutes before I realize afterwards that this patient has an occluded femoral vein from previous cath, and I should have known that. What's the airway doing, making sure the endotracheal tube's not in the right main stem. Cardioversion is sort of a shorthand for it. Is there a predisposition to arrhythmia, or is it a procedure where we're going to need the pads on to shock out of an arrhythmia if we get into one? D is kind of a fun one. That happened after there was contrast sprayed all over the table, so don't forget to connect the contrast to your catheter. Efficiency is just a reminder to kind of move along and not waste too much time. Frame rate, I always drop the frame rate on the fluoro. I'm currently down to 4 for my typical fluoroscopy. And then germs is to talk about whether antibiotics are necessary and what type, heparin, when to give heparin and how much. And then injury, we've had a couple brachial plexus injuries in our adult patients during long cases. And this is something that's really disconcerting because it can be quite the morbidity if they don't recover from it. So this was going to be a little bit of a pick and choose. I don't think I have the hyperlink access to those, so we'll just go through these one at a time. Most of these will start with an angiogram or picture, and you're welcome to kind of shout out what you think it is. One of them, I think, is a predicting what the complication is going to be based upon a chest x-ray. So this is the first one. This is obviously after transcatheter pulmonary valve. Anybody recognize what the complication is here? Say it. I've got another one. The next one will show it a little bit better.
Aneurysm of the superior margin.
Aneurysm of the superior margin. Okay. There's a slight one there. That might actually be sort of a conduit that's left over, a little bit of conduit pocket. That's not what I'm looking at. I'm more looking at the... What's that? Why? Yeah, your output stinks, right? I mean, look at this. This is horrible cardiac output. So exactly right. It just sits there. So this is the next one taken right afterwards. And what's missing here? The left coronary artery is missing, right? Also, this was one of the early cases. This is not one of my complications. Thankfully, I was away doing my training, but
Thank God.
yeah, thankfully, so I can learn from other people's mistakes here. But this is also before we recognized the aortic root compression. There was a little bit of that as well, but there's no left coronary artery here. Okay, so this is obviously a devastating complication. This is just a still frame showing balloon sizing with the 16 millimeter Atlas balloon. And here in this position, when they did it, they occluded the coronary artery. And then they convinced themselves on a subsequent dilation as they advanced the balloon out a little bit further that they were okay. Because here you can see the left coronary artery on a subsequent inflation with the same balloon. So I think they were sort of falsely reassured that we can position this where we think it's going to be safe, and unfortunately that did not work out. And this young lady ended up on ECMO and is now currently listed for a transplant after the stent was removed. So this is a different patient here. This is what coronary artery balloon testing looks like, and when there is compression. So this is a small coronary artery there that we engaged, and you can see with the balloon up there, there's sluggish flow and kind of a slit-like tapering of the coronary right under the balloon. So we did not proceed with transcatheter valve in this patient.
What is that?
What coronary is it?
Yeah.
Yeah, I don't know. We thought it was kind of like a prominent conal branch at first, but it's a weird coronary. It was an isolated single coronary. I don't know what it was. But
I hope there's more. I hope there's more coronary than that.
Well, there was. This was not the only coronary, but this was the one that concerned us. I was going to get your opinion because I looked it over with the adult congenital referring provider, and I'm like, I don't know what coronary this is, and she didn't know either, and she's an imaging person, but in any event,
right.
if you guys don't know either, yeah. So we figured it was big enough to be important that we didn't just want to sort of occlude it. Yeah. Yeah, we think of big pictures here, Eric. We're not you adult cardiologists. So a couple of take-home points. Remembering that coronary compression is or there's a higher risk of that when there's abnormal anatomy or if the coronaries have been reimplanted, particularly in a Ross patient, which was the case with that first one that I showed. And then pre-procedure imaging is very important, especially if you're dealing with small calcified conduits you're going to have to do a lot of work on. So getting a CT angiogram, I think everybody should get one before going to the cath lab. Meticulous testing with balloon inflation, getting the balloon up to the diameter you're going to put the stent up in or the valve up at, and the pressure as well as the location of where it's going to end up. And then if something does happen, you need to be ready to act on it because people can die from this.
Question, Nathan.
Yes?
So, in the case where you have a pre-procedure CTA,
Yeah.
what's your cutoff for a distance between the conduit and the...
We don't have a good cutoff for distance. I think we take a look at the entire picture. So how small is the conduit? Where are we going to need to do the work? If the coronaries are posterior and there's no obstruction there, but it's all proximal, we're going to put the stent in the valve proximal. We figure that that's good enough to take them to the lab. But if it's, I don't know whether 2 millimeters is too close or 3 millimeters, but if we know we're going to be doing a lot of work, we have a pretty low threshold. We're pretty conservative. Pretty low, especially after that one case, pretty low threshold to defer and send them to the surgeon.
I think the CT is good just to show you location.
Right.
But I would not rely at all.
Yeah, and we always do the testing in the lab afterwards. Yep. Yeah. Yeah. So we always.
If it's right under the conduit and it's
If the coronary is
unavoidable.
embedded in the calcium of the conduit,
Well,
that's not a good one. Yeah.
Right.
your coronary is in the other side. not in the conduit.
But I
No,
think
it's going to be, if they're in contact and you have a homograph that's 14 millimeters, you know what I mean? Like, are you going to go ahead with that? Or?
Millimeter, I'm not gonna put a valve.
No, it's a 27 millimeter homograph, but it's 14 millimeters now. It's heavily calcified. The coronary is sitting right on the bottom of the conduit.
Dilatation, as Nathan mentioned.
Okay.
Final balloon until I see what's going on, because the area is there. If it's rigid and rock, then it will not expand. Then when you put a balloon, you will have compression. But if everything is malleable,
So do you ever, and I'm sorry to interrupt,
Sure.
and we're going to save the rest of the questions till the end, but the situation that arises when you dilate a heavily calcified conduit with serial balloons, and then you get a crack, and then you're leaking, but you're like, well, I mean, the coronary is like, what am I going to do here exactly? So, I mean, I think having so,
then what I do,
Yeah.
I will protect the left main with a wire, keep it there, and then I put a stent. If it cracks, because you need to do something, right?
Yeah, yeah.
So before I jump and put the cover the stent, I would wire the coronary, have a guide catheter, have a stent in there, and then I will put the covered stent. If then you have a problem, then you are protected.
okay, let's come back to that, but I want.
it's a
yeah.
big discussion.
Yeah, that's a discussion to have, yeah.
We have time after this talk.
Yeah,
It's a great
yeah.
topic.
All right, so here's the second complication. These are not in any particular order. What's going on here?
Perforation.
Perforation. All right, so this
There,
is,
bronchogram.
yeah.
Let's, do you want to just use the pointer and just point it
Yeah,
out?
okay,
Just,
I'm sorry, thank you. I didn't, I
yeah.
had access to it. So here we got this is actually the same patient, sadly. Obviously, you can tell from these scoliosis wires here, but a couple of different things. We have a pseudoaneurysm down here, and we have a perforation right here. Contrast in the airway, unless you're actually putting it directly in the airway, is something you don't like to see in a cath lab.
Remember that picture.
Yeah, and this was a recent one, a very unfortunate one because we weren't able to put the valve in for other reasons, and she ended up with a brachial injury. I had not seen this before. I had a senior colleague with me who was able to recognize it and knew what we were looking for. Obviously, anesthesia is telling us there's blood in the endotracheal tube, and then we went and investigated. And I probably would have seen that, not known. It would have taken me a while. So she recognized it. We were able to plug this up, and at least that complication was taken care of, which was nice. This is a different patient. Earlier, I was not involved in this, but this just shows where we identified it here, and then they put in a plug. And I think next one, the next one should play, but that just shows it with an AVP2. We used an AVP4 on the first one, AVP2 on this one with good result. Okay. So this is wire trauma, and keeping in mind, we sort of, the knee-jerk reaction when we're doing a pulmonary valve is grab the Lunderquist wire. I hate the Lunderquist wire. I absolutely hate the Lunderquist wire. Now, it's necessary a lot of times, but it's a dangerous wire. This is there's actually a paper out that measures the stiffness of common interventional wires, and this is the rank, 1 being the most stiff to 5 being the least stiff. So as you go through this, look at the patient anatomy, the orientation of the valve, where are you going from point A to point B, how difficult do you think it's going to be to get there with the ensemble system or whatever it is you're using, and then choose your wire accordingly. And it may be the Lunderquist wire every time, but don't just get into that habit of doing that.
I think a number of people in the room would probably argue and say the Meyer and Lunderquist there are reversed.
I think Meyer is different.
Well,
I know you're saying it came from the paper, but everyone who's ever used it,
Okay,
The
all right. Well, then
Meyer-
there may be a question that comes up where the answer is actually recorded incorrectly, but I went by what the paper said, so I don't use the Meyer wire that often, so,
Yeah, it's like a coating.
yeah.
Just unravel coating.
Yeah, so it's a lot cheaper that way too. So I think it's important to get optimal wire position and be aware of your wire position throughout the case, keeping an eye on the tip of the wire, particularly that transition point between the floppy end of the Lunderquist and the stiff end. And then if you do have, we had a couple patients who've needed transcatheter valves who have a Glenn, and that's a wonderful way to do it because you can use a softer wire and the tip of the wire is nowhere near the pulmonary vasculature. And then, of course, if you get blood in the endotracheal tube, if it's anything more than just a little bit, you need to look into that. And then watch it like we saw in that angio, where the contrast goes when you're taking a picture. Contrast in the airway is a bad thing. Okay? Let's see. Case 3. This is the one where we predict what the complication is going to be. It's a guessing game here. Okay? So what are the risk factors? Looking at this chest x-ray for complications. This is a patient who already has one who has a perivalvular leak. We'll give you that. So there's a sapien valve in the pulmonary position with a perivalve leak. So they're going in to try and implant a new valve to close it or to close it with a plug.
Not pre-stented, right?
Not pre-stented, right. It was actually done perventricular in the OR. The original
How
one.
are you predicting perivalvular leak?
Well, it has perivalvular leak. That's the reason for going back in, for either revalve or for plugging the perivalvular leak. And the case was done 2 years ago. This valve was implanted in the OR 2 years ago. Right, but being prepared to revalve if they need to, if they're unable to engage. Any guesses on what's going to? Yeah, just looking at this. Yeah, what are the risk factors? Risk factors are what you think the complication might be.
Of the perivalvular leak?
No, of the current intervention. There's going to be a complication. This is a chest X-ray before the complication. There's going to be a complication. What's it going to be? It's a guessing game.
Valve dislodgement.
Okay, valve dislodgement. Why would you say that?
Well, it's already in a position where you have leaks. So I'm suspecting that probably the positioning and or the sealing is not that good. So
Okay.
I'm suspecting it's already like
Good.
a protoplasm for disaster.
Yep.
And
Yeah.
I also think it's in a big vessel.
And it's a big vessel. So yeah, so a large vessel, it's hard to see here. I got a lot of glare, so I'm not sure exactly where I'm pointing, but a lot of calcification here, big vessel. And we'll see on the angiogram that it's a very complex conduit. So that's a pretty good guess here. So this is the original angio here, particularly on the lateral. You can see there's a leak probably anteriorly here, posteriorly here. There's this aneurysm up here. PA's over there. It's just an ugly valve and a little bit proximal, okay? And it's hard to know what it's hanging on by. Right, well, right, and we'll get to exactly that.
I don't know how you're going to fix this because it's leaking through the top of the frame.
Yeah.
It hasn't fallen down in the RV yet. Well, you can put in a new
Well, so this was another one I was not involved with. Again, I count my blessings, and that's not the brightest. I've lucked out sometimes by being in the right place at the right time or the right place at the wrong time. Yeah, I know. I know. I just email them before I come to conferences. Like, can you send me all your complications?
This is what they're doing in the man.
Yeah. So this was so the plan was to revalve it. They were worried about the stability of the Sapien valve, the original one. So they were deciding to put another one in more distal to try and seal it because there was that ledge right here. They're worried it didn't secure. And of course the balloon pops prior to optimal diameter of the stent. Okay, so that was the next thing that happened. Yeah. And then this is when they're trying to put a plug in to go in and plug this anterior leak here. So these are two sequential cines here. So this is when that plug pops out of place. They had control of it still. But clearly now this is where the original valve used to be up here, and now it's down there. So the valve is becoming dislodged, okay? And then this is the end picture there, which is en route to the OR. Yeah, exactly. So my learning point for this is look at the pre-op testing. So this is day after original implant of the original valve. Okay, and this is 2 years later. She came back to the OR 2 years later for this, or back to the cath lab, excuse me, for the perivalve leak. And so if you look at this, I drew some lines here. I even drew some lines there, and I pulled out my protractor. And that angle there, whatever it's worth, is 18 degrees, and now it's 33. So there's obviously a shift. And I was measuring along the sternal wires here, so something that was reasonably reproducible, I think. So there's clearly a shift.
Do they gate the chest X-rays in Mayo Clinic?
They get the chest X-rays, right? Yeah, I know. But there were enough, and if you look at the calcium, everything else was kind of in the same position except for the valve. So that, of course, this is all with the retrospectoscope looking at it. But something to keep in mind, especially in these complex adults who've had a lot of procedures, a very complex conduit. Make sure you're going through all of the pre-procedure testing and you know what you're getting into. Okay, embolization is rare, but it is the most common reported indication for conversion to open heart valve replacement. That was answering that one question before. Shorter valves seem to be a higher risk, especially if we're not pre-stenting. The Sapien valve accounted for 6 of the 9 embolizations in that meta-analysis. And then maintain your wire position, so because you may need that to prevent the valve from going to bad places as you're taking the patient to the OR. And I'm not a fan of trying to pull them retrograde across the tricuspid valve. I mean, you've already determined the patient needs surgery. I don't see what the utility is in making the surgeon repair the tricuspid valve as well. Okay. This is the fourth one, I think. So this is kind of a complication. This is after successful pulmonary valve implantation here. On the left, the gradient was about 20, so a little high, not too bad, no PR. 2 months later comes in for follow-up, and this is what we see here. So mean gradient 45. What's that? It's a melody. Yep, it's a melody.
Is it pre-stented?
Pre-stented, yeah. So good question. So what are we getting at? We're getting at, we're talking about early dysfunction, stent fracture, melody valve. We're worried about endocarditis. And then this one was actually neither of those, but yeah, thrombosis. Okay, so this is we here see if you can appreciate it here, thickened leaflets, not moving very well. The gradient's up, not a whole lot of PR to speak of, but in the absence of concerning symptoms for endocarditis, in the absence of stent fracture, thrombosis is something. And this was a 23-year-old young lady who was on oral contraceptives, and we thought that might have been part of the problem. 2 months later after warfarin, the gradient is down to 15, her valve looks great. So this is not really a procedural complication, but something we need to be aware of. We talked about other things that can cause early dysfunction. We put these patients afterwards. Unfortunately, maybe we should do it ahead of time, but through a thrombophilia workup. And if there is something, you can hold the oral contraceptives in women and treat them with anticoagulation. We did not, no. We went by echo, and we felt confident enough that with the thickness of the valves and the history of it that we could treat. And sometimes we'll just sort of treat with warfarin for a few months and see if it changes. And in this case, it worked out really well. And so the question is, we treat all our patients with aspirin kind of indefinitely. Should we be treating them like our surgeons do now for 2 to 3 months after valve implantation with oral anticoagulation? And we don't do that standard, but we're probably getting closer to doing that. So something else to keep in mind. Last complication here. This actually has a couple. This was another one of our very early ones, and this complication was not recognized for a while, to be honest, because we did not do, we did a pulmonary angiogram after the Melody valve, but we did not do this picture. Yeah, so we had a fistula. Yeah, so what we're seeing here, we're injecting in the aorta, but we're seeing contrast in the PA, so obviously there's some sort of communication. In addition, as we see now, and I didn't recognize it until I pulled this up again just now because I hadn't looked at it in a couple of years, we have quite a bit of distortion of the aortic root and probably some AI as a result of that. So this is a gentleman who had some symptoms of heart failure right after the procedure, and we thought it was diastolic dysfunction. Now we're just loading his ventricle because we relieved his RVOT obstruction. It actually took him, I think we took about 7 months for us to figure it out because they kept sending him back to the adult lab for coronary angiograms, no offense to but not people who are, and they didn't ever do a right heart cath to look at it. So, and echo for whatever reason didn't pick it up. So he was a Ross, and this was revised, and he did better after that. But this was something that we didn't know was a risk. We've learned is a risk now. Disruption of the conduit, in this case particularly in aorta, pulmonary artery communication. It seems to be more common in people who've had manipulation of both outflow tracts, both the aorta and the PA. The Ross arterial switch may be a risk factor as well. So if you notice sometimes we get these blood pressure changes after we do a valve and we kind of blow it off, but if you notice a widened pulse pressure or hypotension that's not well explained, particularly in a complex case like this, you should investigate it right away. We didn't at the time, and of course wish we had. And it can be difficult to treat. I know there's been success with covered stents. We had another one that was a little bit different. They tried to plug with an ADO that wasn't too successful, and the next day the guy went to surgery. But there are some transcatheter options to try to address it.
We had one, we closed it with a plug.
Mm-hmm. Yeah.
Fistula.
Yeah, the one we tried to was actually RPA. It was an RPA. We dilated an RPA and then put in a valve, and it was yeah.
MPA branch bifurcation junction.
Mm-hmm.
I think what you mentioned earlier about the balloon testing when you're doing your coronary compression testing, when you inflate the balloon, if you are only doing a selective coronary
You
angiogram,
miss the root.
you will not
Yep.
see any distortion of the aorta because you're not injecting there. So having one injection in the aortic root can show you flow into the coronary, but it can also show you the significance of regurgitation and aortic root distortion that can occur.
Yeah, and that's usually what we often will do a root injection first and then selectives if we are not reassured by that, and that gives us a look
So
at
what
both.
do? Do you proceed, or if you find distortion?
Yeah, I don't, I mean, distortion without, if it's, it depends on the degree of distortion. If there's AI, I think we would stop. We haven't seen a whole lot of it, to be honest. We have a lot of bioprosthetic valves, and so we don't really see as many conduits and Rosses per se, but I think that once you start seeing dysfunction of the aortic valve, that's an issue. I don't know that distortion of the root itself would make me think, oh, this is going to cause an erosion. I don't know that we know that. But
As far as I've written up our experience, that was what the TPAM, the change of somewhat, they all change, they're all side by side, but when you start having any kind of AI, it's hard to know what it is because of balloon occlusion, you don't have prograde flow, so you can have that issue, but if you see it instantly and you have the angio just before that doesn't show it, it was the presence of AI that we felt the distortion was beyond what we could do. Rightly or wrongly.
Plus choice of a length of the valve.
Length of the valve,
Which
or
is
length
shorter,
of the balloon
shorter length
sometimes too.
Maybe choose adverse over melody.
Well, there's a nice picture, I think, that who put that one? It was the LA group that put out this nice picture of a sapien valve with this right angle indentation in the aortic roots. I don't know that a short valve necessarily makes all the difference, but. And this is just in summary, this is from this meta-analysis that came out late last year. There's a total rate of serious adverse complications, about 10% in transcatheter pulmonary valves. Conduit disruption was the most common, but didn't often lead to surgery because it was managed in the cath lab. primarily. This, of course, surgical conversion involves several of these, but the most common one that led to surgical conversion was actually the stent and valve dislodgement in this population. Access complications, probably underreported here. That's what they said, and I think those are ones that require blood transfusion and other procedures, so that may be accurate, but lower than I think a lot of us would have predicted. This is common here, pulmonary artery perforation, laceration, sometimes unrecognized, not necessarily needing a whole lot of treatment. We've had some where it's just been a little bit of blood in the endotracheal tube. We haven't had to do anything. They had 5 deaths in their population out of over 1,000. They calculated, based upon a pooled analysis, a rate of about would come out to be 1.8%, which doesn't, the math to my mind doesn't make sense. 5 out of 1,000 is not 1.8%, but somehow I think there's some statistical things to control for biases. And then coronary compression, we're probably getting better at this. There are a lot of these that are hard to predict. Coronary compression, I think that it should be essentially 0. Right? We should be able to predict it and avoid it. And if we're not, we need to kind of reassess either our screening techniques or how aggressive we are in the cath lab. Personally, that's my opinion. But I think that's all I had for you. Any questions?
Do you have post questions, Nathan?
Great talk.
Thank you. Thanks.
Do you have post questions?
Yeah, I think we should have probably
Let's
4
update
now
these
because,
post
oh no, we have
questions.
3 post questions here. Okay.
Oh, yeah. You want to put this first?
And then one of these, when I submitted it, had a video with it. I don't know if that video made it through, but, oh, yeah. Correctly spell the name of the interventional wire that means Grove's twig in Swedish. There you go. You got to spell it correctly, though. That's the tricky part.
Yeah, and you have to overcome your autocorrect.
Isn't it the same as that goalie?
Is that a hockey question?
Yeah.
I haven't been to Minnesota that
What's
long.
that- what's
I've only
that
lived there for
goal- what's
12
that-
years, so I don't.
It's PPVI.
Well, I guess it depends on whether you're reading off the package or whether the original Swedish spelling.
No, the actual name is Quist. They have changed to Quist.
Didn't know you were fluent.
So this is the one we kind of went over this, that I trust the experience of those who've used a Meyer wire as opposed to the paper, but in the paper it did have the stiffest 2 wires flipped, so. Meyer, Linderquist. People are trying to decide whether they want to get this award for the most right or whether they want to actually be right.
So the Super versus the Ultra?
So the Ultra is stiffer than the Super. I've never used the Ultra myself. I pulled it from the paper. We never use the extra stiff in a transcatheter valve, except, when we've externalized it through a Glenn, we've used an extra stiff. Sometimes we use a super stiff, but often still we use a Lunderquist.
Yeah. Okay. One more?
Is there one more or is that it?
Yeah, there is, we weren't able to put the video on.
Yeah.
Can you close this and show it on the slide?
Well, so the video shows a transcatheter pulmonary valve, a Melody valve with thickened leaflets, poor mobility.
Okay.
And
It's
that's
okay,
what the
just
video
put
is.
the question
You
up.
saw it in the talk. Hopefully from the question stem, you should be able to figure out what the answer is. There you go. How about that? Probably should have had this as the pre-test question. But that was it.
The question didn't come up on my phone.
Can you activate the question there?
Plus, I cannot even submit the response.
There we go.
Just one sec. Okay.
You guys are doing great.
And there's one more.
Short-term recall. That's
Yeah.
wonderful.
There's one more question that I think is just kind of interesting because Nathan brought it up. What frame rate are you guys working at routinely? Not for like a long case, but just, I'm interested to know.
It's not active question.
It is.
No, I'm trying to put it, it's not.
Just go back in, go out and go in.
Which one's the parent suppression? Don't say if you say that.
All right. So who's working at 2 frames, by the way?
We work at 3, but there's another 3 up there, so.
Okay.
This depends on if it's a smaller patient, we use 8 guards. If it's a bigger patient, we use 7.5. So
Oh, is that right? Why do you use more frames in an adult?